Well, hello everyone, and I want to thank the organizers for inviting me to give this talk. I'm very, very honored to be here and to be presenting this topic to kick off this conference. What I'm going to be talking about today is recognizing hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. To begin with, this is who I am, Andrew Maxwell, and I am a pediatric cardiologist in the San Francisco Bay Area. And I have a quite large population of patients with dysautonomia as part of being a pediatric cardiologist. And consequently, through close association, have quite a number of patients with hypermobility spectrum disorders. I have no disclosures. A few years ago, I was given the honor of writing the chapter on dysautonomia in Disjointed, which has become sort of the Bible for patients with Ehlers-Danlos syndromes and hypermobile spectrum disorders. So what we're going to learn today, we're going to discuss the clinical recognition of hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. I'm going to briefly go over the classification of the subtypes of Ehlers-Danlos syndromes, and then focus the rest of the talk mainly on hypermobility spectrum disorders and hypermobile Ehlers-Danlos syndromes, particularly the diagnostic criteria for determining their presence, closely associated disorders, what I call the pentad, as we'll discuss, and then pathology associated with hypermobility spectrum disorders, what I call the syndromes of SAG, and potential updates and alternatives to the current criteria we use. Well, we can't really talk about how to identify hypermobility spectrum disorders unless we have a good working definition of what they are. So what are hypermobility disorders to begin with? They are genetically connected issues with connective tissue disease in a nutshell. And that's a very vague and poor description of them. And that really is to do with where we are with the state of understanding of hypermobility spectrum disorders. We're really in the nascent period of understanding it. So, how are we going to identify it if it's poorly understood? Well, I think part of it is understanding that even though we believe it's genetically related, the underpinnings are genetics, that there's a big environmental component. And so these patients tend to be what I would refer to as the canary in the coal mine. These are genetically vulnerable hosts that their conditions are brought out further, at least, by elements of the environment. I'm going to leave environment, a very vague term here, because it can mean a lot of different things. And so that genetically vulnerable host, subjected to the right conditions, develops a breakdown in their connective tissue, and they express themselves in hypermobility. And I think, again, how can we identify such patients when it's so poorly defined? And I believe the late Chief Justice William Rehnquist put it best, that even though they may not be able to define it, they know it when they see it. And that's what we want to do today. We want to make folks aware of the presentation, the wide varied presentation that these patients have that allows us to suspect that they have it and further work them up. And again, in a nutshell, how to suspect it, you may remember this mantra: if you can't connect the issues, think connective tissues. And that is given to Heidi Collins, who that's attributed to. Okay, so when to suspect hypermobility disorders? If you have patients that come in with chronic joint instabilities, chronic widespread pain. And I emphasize pain because it's not just necessarily pain in their joints. It can be widespread pain, fibromyalgia type pain, chronic uh, pains of other type, pains related to some of these conditions we're going to mention below that have nothing to do with joints. Chronic abdominal and pelvic symptoms, postural symptoms, poor fine motor skills, particularly with handwriting, proprioception challenges, not knowing where your body parts are in space, bruising and bleeding issues, presence of co-conditions of what I call the pentad, which includes dysautonomia, including POTS, gastrointestinal dysfunction, allergy, atopy, mast cell activation syndromes, MCAS, and autoimmunity. Then there's the ptoses, or the sagging organs that are commonly associated, and other physical findings. Some of those other physical findings include blue sclera, signs of obstructive sleep apnea. Here I have a image of an open mouth demonstrating what's called the Malin-Potty score, which is very often used by anesthesiologists when deciding if they need to pay particular attention to the oral airway with these patients undergoing anesthesia. Translucent skin, chest wall deformities, scoliosis, joint deformities, and various hernias of various types. Okay, let's talk about joint issues to begin with. Dislocations versus subluxations. Dislocations, of course, is the complete disruption of the integrity of the joint, where the two bones are no longer associated with each other, as opposed to subluxation, where it's just increased mobility and movement of one bone relative to another bone within the joint, but not completely dislocated. So which joints are most affected? Really, all of them are affected throughout the body. If you were to look and talk to physical therapists and those sports physicians dealing with patients with hypermobility, they would say shoulders, knees, thumbs, and ankles are the biggest ones. In my practice, I see a lot of rib dislocations, and that's probably because I'm a pediatric cardiologist. So these patients are coming in with chest pain, wanting to make sure that it's not cardiac in origin. But I also see a lot of cervical vertebral dislocations, craniocervical instability specifically, and temporomandibular joint dysfunction and dislocations. So I think those should be added high on the list as well. Classification. So in 2017, the International Consortium on Ehlers-Danlos Syndromes got together and came up with an update of the classification of Ehlers-Danlos syndromes, and also the criteria for diagnosing specifically hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. And to begin with, they reclassified all the different types of Ehlers-Danlos syndromes. And there's many different types, and there's always a new one being added. We're going to focus the rest of the talk on hypermobile Ehlers-Danlos syndromes and hypermobility spectrum disorders. So really those two. But before going on to that, I do want to mention that the others do have genetics that are associated with them, and they're also not completely worked out genetics because each of those types can have various different genes that are associated with them. So they need some working out of the genetic details as well. But in contrast to those, we're still looking for any of the genetics related to hypermobile Ehlers-Danlos syndrome. And that is being worked on. And one group in particular, the Norris Lab, and kudos to Courtney Gensimer, who has done a lot of this work, has found one particular gene of interest. and has put that into at least pre-publication format, hoping that that will be published soon. And what they found is that there seems to be variance, rare pathologic variance in the kallikrein gene, which encodes for kallikrein-related peptidases, which are a broad spectrum of serine proteases that have diverse functions throughout the body and diverse physiologic roles, and would potentially explain the diverse presentations of patients with hypermobile Ehlers-Danlos syndrome. And they specifically found about 33% of patients that are unrelated that have hypermobile Ehlers-Danlos syndromes have rare pathologic variants in this gene. And so this is looking promising. They actually inserted the variant gene into mice and found that those mice displayed changes consistent with hypermobile Ehlers-Danlos syndrome. So they then turn their attention to producing a set of criterion to help identify patients with hypermobile Ehlers-Danlos syndrome. And that was in 2017. And since then, it's received a lot of feedback that indicate that there'll probably be new criterion necessary and soon coming. And what they did was they broke this up into three criterion that needed criteria that needed to all be present. Criteria 1, 2, and 3. The first is generalized joint hypermobility, criterion number 1, and that is through what's called the Beighton score, and that has some a minor component of being dependent on age. So a Beighton score of 6 or greater is needed for prepubertal children, 5 or greater for after puberty, and 4 or greater for those over 50 years of age. Okay, the specifics of the Beighton score are shown here, looking at the flexibility of the pinky beyond 90 degrees for both pinkies, 1 point each. The ability of the thumb to touch the arm, each arm, 1 point each. The ability of the arm to hyperextend, 1 point each. The ability of the knees to hyperflex, 1 point each. And finally, the ability to stand flat on the floor and bend over and put your palms flat on the floor, 1 point for that. So a total of 9 possible. Criterion 2 is looking at physical features, and 5 of 12 possible physical features must be met. I'm not going to go through each one of these specifically, but I'll show you a few examples here in picture. And for instance, the flexibility, increased extensibility of the skin, and also stria of the skin in particular places that are not related to recent loss of weight or rapid growth. There's something called pisogenic papules that are at the heels, and this is basically fat herniating through connective tissue in the heel, and so that should be done while a patient is standing with their full weight on their heel, on their feet, so that there's weight on their heels to generate these pisogenic papules. There is abnormal scarring, usually a paper-thin type of scarring. There's crowded teeth and high-arched palate. And finally, signs that either your fingers are excessively long or increased flexible through what's called the wrist and thumb sign, or the Steinberg and Wallach-Murdoch signs. Increased wingspan, greater than height, is also present. Okay, feature B is related to family history. And specifically, is there one or more first-degree relatives who have met this same criteria for hypermobile Ehlers-Danlos? And feature C is related to pain and joint dislocations. So specifically, musculoskeletal pain in two or more limbs recurring for at least 3 months on a daily basis, chronic widespread pain for more than 3 months, and recurrent joint dislocations or frank joint instability absent of trauma. So criteria number 2 requires 2 of 3 of those features. Criterion 3 is really making sure there's not an alternative diagnosis. So making sure that there's not a different type of heritable connective tissue disorder, or that there is a underlying autoimmune disorder or anything else that would explain the findings. At the other end of the spectrum, the hypermobility spectrum disorders, the criteria are quite simple and the bar is set quite low. So this kind of catches all those that you know are not quite right with their hypermobility, but are not meeting Ehlers-Danlos criteria. And that really boils down to 5 simple questions. Do you answer yes to at least 2 of these questions? Can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulders or kneecaps dislocate on more than one occasion? Do you consider yourself double jointed? So if you can answer 2 of those questions yes to those 5 questions, then you could be labeled as hypermobile spectrum disorder. Very low bar and very different from the strict criteria set for hypermobile Ehlers-Danlos syndrome. Well, there's a lot of limitations to those criteria. For one, there's a strong distal bias in age. In other words, it was very, very difficult to have a pediatric patient meet the 2017 criteria for hypermobile Ehlers-Danlos. It's also difficult to evaluate in children and adolescents. Another thing is that hypermobility and instability are not the same thing. There are hypermobile parts of the body that, in children in particular, that aren't truly pathologic or considered an instability situation. It relies heavily on the Beighton score, and a lot of patients will not necessarily be hypermobile in the joints that the Beighton score assesses, but will be hypermobile in other joints. So that excludes those patients that are hypermobile in other joints. While on the other hand, providers may realize that these patients are hypermobile in other joints and utilize those to embellish the Beighton score. Not necessarily a wrong thing to do, but if you're a purist looking for a reliable Beighton score for, let's say, research purposes, this may be an unfair embellishment in that case. Okay, finally, there's a vast diagnostic bar between the criteria for hypermobile Ehlers-Danlos syndrome and hypermobile spectrum disorders. In other words, very, very difficult to achieve the first diagnosis, very, very easy to achieve the second diagnosis, and perhaps even such that it's considered overly diagnosed for the second. Some of those other joints that are hypermobile that don't show up on the Beighton score can be, wing scapula and just various other joints that are clearly hypermobile but are not showing up on the Beighton score. Another limitation is some of these measurement techniques are not very accurate. And here's a picture of one that is particularly problematic. Well, the group got together more recently in 2023. They published these new criteria specific to pediatrics to address this issue of pediatric patients not easily being diagnosed with hypermobile Ehlers-Danlos syndrome. And they still have the very same Beighton score on that, but they've limited the tissue features to just 6 rather than the 12 of the adults, and a minimum of 3 rather than 5 must be met for this. They also they added on another group, musculoskeletal complications, in a different way, at least, not describing pain in the terms of joints being dislocatable in a certain amount of time, but rather episodic activity related to pain, not meeting the chronic pain frequency and duration criteria, recurrent joint dislocations and subluxation in the absence of trauma, and soft tissue injuries, one major needing surgical repair, and or current multiple minor, such as tendon and ligament tears. 2 of the 3 of those are necessary. And then they brought in comorbidities, recognizing co-conditions and other pathologies, chronic primary pain, chronic fatigue, functional GI disorders, functional bladder disorders, primary dysautonomia, and even anxiety. So recognizing in this newer version, at least for pediatrics, that there's a bigger picture here that needs to be addressed. And they came up with a pain scale that can be used particularly for the very young children. Well, in my practice, we looked at the frequency of these conditions based on their definition, and we looked specifically in POTS patients. So we took 100 POTS patients to determine how many met criteria for hypermobile Ehlers-Danlos and how many met criteria for hypermobile spectrum disorder. So with this strict N, 13 of the 100 POTS patients met criteria for hypermobility Ehlers-Danlos, while 34 met criteria for hypermobility spectrum. And then we also looked at what if we said near hypermobile Ehlers-Danlos syndrome. So instead of requiring 2 of 3 of those features under criterion 2, we only required one of those features, but also required that they have one of the pathologies we're going to be talking about coming up soon, one of the syndromes of SAG that we're going to be coming up with. And there, those patients nearly meeting hypermobile Ehlers-Danlos syndrome requirements jumped up to 31. Okay, what are the closely associated disorders we've been talking about? These are what I term the pentad. And what that is basically we've got the hypermobility spectrum disorders, but closely associated to that are dysautonomias of various type, including POTS, mast cell activation syndrome, very common in hypermobility spectrum disorders. And with those 3 together, usually there's a lot of GI dysmotility, gastrointestinal dysmotility. And oftentimes autoimmune disease is associated with these. So these occur so frequently together, they were determined the pentad supersyndrome, and it provides a framework for how other subsyndromes end up attaching to them, as we'll see in a moment. But first, I want to talk a little bit about what mast cell activation syndrome is. So we all know what mast cells are in the body. They're the little cells in the part of the white blood cell system, part of the immune system that, in this particular case, secretes histamine and creates allergies. But mast cells are much, much bigger than that. They secrete a lot more things, thousands of components that they secrete. Histamine is just one of them. Other components that are really important, for instance, heparin. Heparin is secreted in higher amounts in mast cells that are activated and probably contribute in some way to the bleeding diathesis that we see with these patients. Then there are tryptases and proteases. These are enzymes that break down proteins and elastin. Okay, and finally are mediators of inflammation, such as TNF alpha. So how does these tryptases and elastases affect patients that have hypermobility syndrome. So, as we said, mast cells secrete elastase. Elastase 2 specifically cleaves what are called cadherins. Cadherins are connector proteins in the body. They are responsible for holding fibrous tissue together. And so when they are broken down, they probably contribute to the tenderization of connective tissue, making a person a little bit more hypermobile than they would be otherwise. They also break down E-cadherins, which hold together GI epithelium. And breaking these down create what's called leaky gut. They also break down cadherins in the endothelium and create a leaky blood-brain barrier and leaky capillaries. So elastases secreted by mast cells can affect a lot of the things that we see in patients with hypermobility. Okay, then there's dysautonomia. And this is a very, very big topic. I could talk all day on this, but in one brief slide, dysautonomia is the dysfunction of the autonomic nervous system, particularly the parasympathetic nervous system, and most notably, the vagus nerve of the parasympathetic nervous system, which is the largest nerve in the parasympathetic nervous system. You'll see some of the consequences of that coming up when we talk about some of these syndromes of SAG. So all of these 5 entities put into a scaffolding allow one to add in the many subsyndromes that are seen in these patients. And I think this is useful because that it allows for a clinician to say, okay, I found that my patient has something like CRPS, chronic regional pain syndrome. I should be highly suspicious that this patient has mast cell activation syndrome. Or consequently, or in converse, I've just diagnosed what I think is mast cell activation syndrome in my patient. I should be on high alert for all these subsyndromes connected over here. And that's also true for the Ehlers-Danlos spectrum disorders, the hypermobility spectrum disorders. If you have a patient who comes in with, say, tethered cord, you should have a high index of suspicion that these patients have a hypermobility spectrum disorder. Conversely, if you believe your patient is now diagnosed with hypermobility spectrum disorders, you should be on high alert for all of these associated subsyndromes. So that's how this paradigm works here. When looking again at our patients in my practice, we looked at 392 patients that had dysautonomia of various types, what we call orthostatic intolerance dysautonomias. 100 met strict criteria for POTS. Of those 100 with POTS, 78% of those ended up being clinically diagnosed with mast cell activation syndrome. So that's how common it is. Nearly every one of those patients, when trialed on mast cell suppressing agents, felt better, not just with their mast cell symptoms, but all their symptoms, the POTS symptoms and all, had an improvement. So mast cell activation syndrome is very, very common in this population, particularly those that meet POTS criteria. Hypermobility spectrum disorder was found in 34 of them. Of those 34, 33 patients met criteria for the triad, meaning all 3, dysautonomia, mast cell activation syndrome, and hypermobility spectrum disorder. So they had all 3. 33% of all the POTS patients met all 3. And really, when you think about the starting place that these patients have, they may all start in different places. There may be people coming in with pure autonomic dysfunction, pure vagal nerve dysfunction, or those who early on identify as having hypermobile Ehlers-Danlos, or those early on that are showing signs of autoimmunity, or those early on who are showing gastrointestinal problems, IBS, things like that, or those early on who are showing sensitivities to their environment, as in allergies, and end up being ultimately diagnosed with mast cell activation syndrome. It almost doesn't matter how they start. They eventually all end up in the same place, that they're looking like these pentad patients. Okay, when we see some of these sicker patients, we see the very, very long list of signs and symptoms they have, and it really covers just about every organ system of the body. And so when you, again, see unrelated issues, poorly defined issues, think connective tissues. And that's what we're going to do, but we're going to do it with this framework of the pentad. And we realize once we understand that dysautonomia and mast cell activation syndrome are often found together with the hypermobility spectrums, we realize that some of these symptoms are created by the dysautonomia, some are by mast cell activation syndrome, and some are by the hypermobility issues. Okay, now I'm going to talk about this concept of the syndrome of sag, that hypermobile patients have sagging organs, also known as ptoses. Okay, and I'm going to go from top to bottom here, top of the head to the toes, and talk about all the things that sag. To begin with, there is the cerebroptoses, which might be represented by Chiari malformation, and we'll show some images of that. Cranioptoses, settling of the skull on the vertebrae, and that creates vertebral-basilar insufficiency, oftentimes showing up as brain fog. Allantoptoses, so slipping forward of C1, creating craniocervical instability, and what I call pseudo-eagle syndrome, often resulting in a lot of pain and other symptoms. Mandibuloptoses, so the sagging of the TMJ dysfunction, not TJM, TMJ dysfunction, with airway obstruction and often with pain. There's airway ptoses, sagging of the airway, creating upper airway resistance syndrome and maybe even frank obstructive sleep apnea. The combination of all of those above just mentioned results in patients sometimes having idiopathic intracranial hypertension, CSF leak, and this syndrome we've described called spiky leaky syndrome. Below that, we have vertebroptoses, creating scoliosis and kyphosis, venotosis or hematosis, sagging of the veins in the body and sagging of the blood volume with gravity, creating a POTS situation. And then there's viscerotoses, sagging of abdominal contents, large bowel, small bowel, herniations, prolapses within the abdomen. Diaphragmtoses, creating median articulate ligament syndrome, resulting in either neuromals or vascular mals. Abdominal vascular ptoses, creating superior mesenteric artery syndrome and nutcracker syndrome. Pelvic vascular ptoses, pelvic congestion syndromes resulting, including May-Thurner syndrome. Nephrotoses, the sagging of the kidneys, creating renal dysfunction and hypertension. Articulotoses, this is the subluxation and joint dislocations we've already described. And heel fascial ptoses, creating piezogenic papules. And plantar fascial ptoses, creating flat feet. So let's talk about some of these, again, from head to toe. At the top, we've got the Chiari malformation. Sometimes this is as simple as regular but low-lying tonsils of the cerebellum slipping into the foramen magnum of the C1. Allantoptoses, whereby the C1 slips forward. We call this craniocervical instability. And with C1 slipping forward, there is compression of soft tissues against the stylohyoid ligament. And sometimes that's painful, creating Eagle syndrome type pain, but it's not true Eagle syndrome because the styloid bone is not necessarily excessively long. So these soft tissues are not just the internal jugular vein, but everything within the carotid sheath that includes the internal jugular vein, the carotid artery, and others, as we'll see in a moment. It also flattens out and compresses the vertebral artery, which is delivering blood to the brainstem, therefore causing vertebral basilar insufficiency with the associated symptoms of that. So these soft tissue structures that are within this carotid sheath that get compressed between the tubercle, the lateral tubercle of C1, and the stylohyoid ligament include four very important cranial nerves, 9, 10, 11, and 12. And when they get compressed, and injured, just like carpal tunnel syndrome, this would be called the carpal tunnel syndrome of the neck, they become dysfunctional and create pain and create motor dysfunction. And there's a whole list of cranial neuropathies, cranial nerve neuropathies that occur at this site. This is often made worse with the position that Ehlers-Danlos patients often display, with this head forward position or sniffing position, worsens the carpal tunnel syndrome of the neck. Sometimes part of this is called cervical dystructure, and another part of it is cervicovagopathy, but that's not limited to those two issues. There's also other things that are affected besides the vagus nerve. And this is thought to be even more prevalent these days now that everyone is using their cell phones and in this position a lot with cell phone viewing. This can be looked at with digital motion x-rays of the cervical spine. And these are a couple examples of at least the still images. And if you could imagine them being in motion, they would be much more telling of ways that the instability can be seen. And I think that it's most easily seen when you have the patient turning their head, leaning their head from one side to the other. You can actually see the C1 as relative to position to C2 slipping to the left when leaning left and slipping to the right when leaning right. So one of the better ways to assess craniocervical instability in these patients. You can use CT angiograms and MRIs, and usually what you're seeing here are telltale signs such as the compression of the jugular vein between the lateral tubercle of C1 and the styloid bone. And you can see that in axial view here with the jugular vein being compressed. And that might be seen on three-dimensional images, the CD angio reconstructions with, again, the internal jugular vein here being compressed. So when you see a patient that has craniocervical instability and you found that they have upper airway resistance syndrome and they tend to be having headaches consistent with high intracranial pressure and low intracranial pressure, and maybe even have signs of what's called Eagle syndrome and CSF leak, then you should be thinking of this phenomenon we've called spiky leaky syndrome. And in order to look at the airways of these patients, we often do cone beam CT scans, and that produces very nice hard tissue and soft tissue imaging, and you can apply a computer program to the airway to look at the adequacy of the airway. And when you look at that here, you see three patients side by side. The first patient here on the left has a wide open airway, all green. The patient here in the middle has a narrow airway, long segment narrowing, probably the tongue pushed too far back, maybe because the TMJ is dislocated posteriorly, maybe because the tongue is too big, maybe too soft of tissues of the airway in general. And this last patient has a very short segment narrowing, and I'm going to zero in on that. But you can see how these patients will often have just a very slit-like airway. And this is in an upright position that we're finding this. It's probably even worse when they're lying flat. But in this particular patient, this short segment narrowing is right in front of the arch of C1. So the question on this patient is C1 slipping forward, as it appears to be in this image, and narrowing the airway from the rear? When we see patients like that, and we do sleep studies on them and find they have upper airway resistance syndrome, meaning they retain carbon dioxide when they sleep at night, and they have signs of craniocervical instability where they have the jugular vein compressed, thereby interfering with the drainage of CSF out of their skull, then they're set up for nighttime spikes in their CSF pressure, what we call the spiky phase of spiky leaky syndrome. Some of these patients we found tend to spike so high that they actually leak their CSF fluid into their nasal sinuses and create a CSF leak type of headache afterward. So that's the leaky phase of spiky leaky syndrome. And we found in those same 100 POTS patients, actually the nearly 400 dysautonomia patients, we found about 9% of those with POTS ended up having full spiky leaky syndrome where they leak CSF, and 33% had evidence of craniocervical instability, upper airway resistance syndrome, hyperventilation during the daytime, and chronic orthostatic headaches that alternated between a high pressure headache and a low pressure headache. Maybe not fully leaking, but we're on their way. So when you add in craniocervical instability, upper airway resistance syndrome, CSF leak, and full spiky leaky syndrome, you start to have a fourth category that these patients' symptoms fall into. Again, just a improving framework for how we understand where all these symptoms come from. We published that finding on spiky leaky syndrome this February, and it's actually showing up as a chapter in a textbook on pediatric and adult breathing disorders during sleep. This February, simultaneous with our publication, was another group from Wake Forest who characterized the very same phenotype, but from a neurosurgical standpoint. And they found the very same population we've been describing. And I'm highlighting a few of those characteristics and conditions they found associated with these patients because they look very familiar. Postural orthostatic tachycardia syndrome in 56% of these patients. Dysautonomia in general, 45%. Joint hypermobility, very common. Cranial cervical instability, mast cell activation, Chiari malformation, tethered cord, obstructive sleep apnea, nutcracker syndrome, May-Thurner syndrome. These are all things that we're seeing in these patients that we're talking about today. Okay, let's talk about a little bit further down in the body. Hematosis, sagging of the blood volume. Okay, what happens when that happens? When you're lying flat, blood volume is easily distributed. When you sit up and stand up, blood volume needs to be distributed throughout the body differently. And that's usually part of the autonomic nervous system and a great extent to the connective tissue that determines how well that's done. But in patients with hypermobile spectrum disorders, this is what happens. This is at least how the patient describes what happens. But this is how you might see these patients when you look at their lower extremities. They often have engorgement of their lower extremities as blood pools downward. But now we understand that a lot of these patients are actually pooling blood in their pelvic region, creating what's called pelvic congestion syndrome. From a cardiovascular standpoint, what we're seeing is this phenomenon of the central venous pool sagging away from the heart. And that sagging away makes it difficult for blood to enter the heart when it asks for more blood. So you can imagine the heart opening up, relaxing, the ventricles opening up, and basically having very low pressure so that the blood can passively fill the chambers. And you lose that preload. If you lose the preload, you lose the stroke volume. If you lose the stroke volume, all other things being equal, cardiac output falls off. When that happens, all else being equal, cerebral perfusion falls off. Okay, so that is the core concept behind POTS. And you might think of this sag in this way, and maybe you'll always remember that sag in this way. And this is courtesy of the internet. So why does that sag occur? Why is there a saggy balloon type situation going on? Well, two main reasons. The first is dysfunction of the autonomic nervous system, as we described earlier. And the second is actual compliance issue of the connective tissue, the veins. Okay, so those increased compliance and dysfunctional autonomic nervous system causes the blood volume to sag. And every patient has some contribution of those two entities making up their POTS-like situation. Viscerotoses, another syndrome of sag. This is where the abdominal organs sag down inappropriately in the abdomen, and it can be small bowel or large bowel. This first image is that of the large bowel in the appropriate position. This picture here shows a contrast study with the small bowel down in the pelvis. And the same is found here with the large bowel down in the pelvis. There's also other prolapses such as uterine prolapse and rectal prolapse. Okay, sagging of the diaphragm. That leads to something called MALS, median articulate ligament syndrome, medium arcuate ligament syndrome. And so you can imagine the arcuate ligament being right above the celiac artery in normal position and sagging down such that it rubs on not just the artery, but more importantly, the celiac nerve plexus. And that injury to the celiac nerve plexus causes most of the issues in these patients with severe epigastric pain, usually immediately after eating, and bowel dysmotility where they're unable to move contents in their GI tract. Usually, this requires a snipping away of the arcuate ligament by the surgeon, but also repair of the celiac artery and doing something to the celiac plexus to relieve the pain. Slightly further down is SMA syndrome, a sagging of the superior mesenteric artery, often because of loss of fat between the aorta and the superior mesenteric artery, compressing the duodenum. And that can be suspected when these patients, maybe 30 minutes after eating, have abdominal pain, not in the epigastric region, but a little bit lower, closer to the belly button, in the midline, as opposed to being slightly off to the left with MALS. And they will show radiographic signs such as the contrast image shown here, as well as CT angios and sonograms that may show a narrow SMA angle and higher velocity flow by sonogram. As part of that SMA having a narrow angle, it can also compress the renal vein, the left renal vein specifically, and create what's called nutcracker syndrome. And that can lead to left kidney dysfunction and issues along those lines, including hypertension. Also, just below that is May-Thurner syndrome, sagging of the arteries onto the left iliac vein. And that can compress the left iliac vein and create problems of blood flow return from the left leg, particularly, and it can be extensive enough to create a POTS-like situation. So some patients who have gotten their iliac vein restored in flow will have their POTS resolve as a result of that. Here's some imaging provided by Meredith McDermott, who is a interventional radiologist who takes care of these patients with pelvic pain syndromes, showing different imaging here, such as the development of collaterals that these patients will often need to produce in order to get blood flow back to the heart. Here's a gonadal varice caused by blood pooling down in the gonadal vein. And then finally, dilated and varicose veins within the pelvic floor, again from pelvic congestion issues. Okay, so those are some consequences of sagging of organs and hyperdistensibility of connective tissue, such as in the veins. Now I want to go back and talk about how these classifications and particularly the criteria for diagnosis might be improved. Well, the same International Consortium of Ehlers-Danlos reconvened and brought in other groups, the Ehlers-Danlos Society, the International Consortium on Ehlers-Danlos Syndromes and Hypermobility Spectrum Disorders, selected European reference networks such as those listed below, and even various patient associations so that everybody could get together and make sure everyone is as happy as they can be about how to best diagnose and classify these patients. That's still a work in progress, but what they have come to work with here is deciding that they need to discuss and identify methods for assessing the presence of generalized joint hypermobility that will allow a clinician to better identify generalized joint hypermobility, something beyond the Beighton score. Determining if the signs and complications considered typical of hypermobile Ehlers-Danlos and hypermobility spectrum disorders are sufficiently described. In other words, making sure the co-conditions are included, making sure the syndromes of SAG are included. Identify which additional signs and complications should be added to the criteria to support the clinical assessment. And then whether all signs should remain equal to each other. So some things are clearly higher specificity than others and should be weighed more heavily when considering the presence of these conditions. They also want to make sure they're including associated conditions, as I mentioned, dysautonomias, mast cell activation syndromes being the big ones, and whether they should be included in the criteria or at least flagged so that they're thought about. Identify which specific adjustments need to be made to be appropriate for children and young adults. So as we mentioned, it's very biased, the old criteria, very biased toward adults. That's been improved in 2023 and probably further improved with the next set of criteria. We also need to determine how useful the family history component is and how it should be used. Right now, it's one of the 3 features of criterion 2, such that many patients are simply waiting to be called hypermobile Ehlers-Danlos for the moment of family members meet that criteria. So one moment they aren't diagnosed with hypermobile Ehlers-Danlos, then a family member announces they are, and suddenly that young patient is given the diagnosis of hypermobile Ehlers-Danlos simply because another family member was found to have it. So that has always been a bother to a lot of clinicians, and so this will hopefully be addressed in the next version. Finally, exploring concerns that have been raised surrounding the naming of hypermobile Ehlers-Danlos and hypermobility spectrum disorders, and particularly the wide gap between the diagnosis of the two. So for anyone who wishes to have more information on this, of course, there's a lot of sources for this, but I think a very, very good review that is constantly being updated is one provided by HACM, Hypermobile Ehlers-Danlos Syndrome, and that is found on the internet. And these are the identifiers so that you can find it easily. It was first posted in 2004, but has been updated as recently as this last February, so constantly being updated. Very, very good source. Well, I hope this explains Ehlers-Danlos syndrome as best as it can be explained with the understanding that we currently have with this condition. Thank you very much for your time.